is Ashraf Al-Zaabi. I'm a pulmonologist from Zayed Military Hospital, and I'm currently serving as the president of the Emirates Thoracic Society in UAE. It gives me a great pleasure to invite you to our regular symposiums for the Emirates Thoracic Society, ETS group. Today, we are honored to have the respiratory infection group representing the ETS, and that is going to be represented by the president of the ETS respiratory infection group, and that's Professor Imad from Al-Zahra Hospital, and Dr. Haris from Dubai, who's going to give us two talks. These two talks are going to be followed by another session chaired by Dr. Muhammad Abu Zarqouk from Cleveland Clinic, Abu Dhabi. And during the second session, we're going to be speaking in particular about severe asthma. So in today's meeting, we're going to have two main topics: respiratory infections and severe asthma for the second session. Each session is going to be around 20 minutes, including the discussion time, 20 to 25 minutes. Professor Imad is going to be giving the third session and chairing the first part of the day.
Okay. Thank you, Professor Ashraf, for just a great opportunity and invitation. And actually, it's a great pleasure to have you on the head of Emirates Thoracic Society. It has been so much great development of the society since you have been sharing this one. And today meeting is one of the best meetings we will have today. And the first part of the meeting will be about respiratory tract infections group. And I'll have the pleasure to have my colleague, Dr. Muhammad Haris from Medcare, and he's the secretary of the infection control of infection respiratory tract group. And Dr. Haris is a very excellent speaker and clinician, and I have a great pleasure to introduce him to talk to us today about management of hospital-acquired pneumonia in COVID era. This will be followed by my talk about improving antibiotic strategies in the hospital setting. So please, Dr. Haris, join us. And that's why we choose this topic, because all of us in respiratory medicine have this problem when you have patients admitted in the ICUs or in the hospital with COVID, and you have to treat there from complications pneumonia. We have Dr. Muhammad Haris, and please welcome him, and I am sure you will enjoy too much his meeting.
Good evening, everybody. Today it's a very, very relevant topic, and thank you again, Professor Imad Al-Din and my dear colleague, Dr. Imad and Professor Ashraf Al-Zaabi to give me this opportunity. I would be talking about management of hospital-acquired pneumonia in this COVID time. It's a bit difficult topic because there are a lot of literature happening without some of the literature is without much substance. So bacterial co-infections are so common, not so common. We think that it's very common, but this study by Sarah M. Karaba, it's a multi-center study and published in Open Forum Infectious Disease, which shows that respiratory bacterial co-infections are infrequent in COVID-19. And this total series of cases, they had one patient proven bacterial community-acquired pneumonia, and 11 had probable bacterial community-acquired pneumonia. 2 patients had viral respiratory co-infections. But on the other side, 69% of the patients actually received antibiotics. So we are over-prescribing antibiotic in any case. If we are still continuing, that I think none of us, including myself, can stop immediately that habit. So maybe we need more data, more evidence that we don't have to use antibiotics. But like in a vast spectrum now, a lot of people, they are not going to any doctor like the the first episode of COVID. So they just take paracetamol. So if you consider that, maybe our total prescriptions in COVID-19 may be not like 69%, it's maybe less than 40% in current scenario. So how to differentiate in a general practice side, like between this bacterial and viral pneumonia? There is no hard and fast rule. It's published from University of Oxford. The patient present with a history of typical COVID-19 symptoms, cough, temperature for around 7 days, has severe myalgia, altered sense of taste or smell. It doesn't happen in all the cases. Is breathless but has no pleuritic chest pain, because usually the other side, bacterial pneumonia is associated with pleurisy, and a history of exposure to known or suspected COVID-19 at workplace or at house. But on the other side, bacterial pneumonias become rapidly unwell after a few days of unwell, the patient feel unwell, then immediately they went into pneumonia, high-grade fever, then breathing difficulty and all these things. And they don't have a typical symptoms of COVID-19. And the patient may have a pleuritic chest pain, and most of the cases in bacterial pneumonias, they have purulent sputum unless it's an atypical pneumonia. But again, this is actually a multi-center study and a meta-analysis. Again, it was showing 3.5% of co-infection on presentation and 14.3 secondary infection after presentation, but almost 72% of people were getting antibiotics. So that is the situation. That's not only UAE or including China, everywhere, all over the world, it's included. So this is like a big study published recently in January only. That is around more than 10,000, 13,000 people were tested, and 1,000 persons were identified as having COVID-19, and around 220 were hospitalized. With this, actually, consent was not given by some of the people. So 161 patients were selected for the study, and they followed up how this and infections happened in these cases. So in the final cohort of 162 patients, median age of around 65 years, and 61.1% were male, and 41 patients were admitted to the ICU. So out of 41 admitted to the ICU, 34 required mechanical ventilation, and 17 of all hospitalized patients died. So among the hospitalized patients, almost it is like 10% death. And among these admitted patients, 34 infections were diagnosed, including 5 viral co-infections, 24 bacterial infections, and 3 fungal infections. So ventilator-associated pneumonia was now 5 cases, tracheobronchitis in 13 cases, and bloodstream infection in 6 cases. So respiratory infection was developing almost after 12 days, and the bloodstream infection was almost after 14 days. So the infections after admission to hospital, it is like prevalence is a bit higher. So, but like in a community, as I mentioned earlier, it's not higher. But the people, once they admitted into the hospital, some of these patients actually develop infections. So, but in any COVID era or non-COVID era, the real question is that whether I need to use antibiotic or not. Before taking a decision, there are 4 questions we need to answer. Does my patient have an infection that requires antibiotic? Is it really a bacterial infection which needs an antibiotic, or a fungal infection which needs an antifungal? Or next question is how I ordered appropriate cultures before starting antibiotics, and what empiric therapy I should initiate. A day or more has passed. You decided on antibiotic, and maybe by like pressure from your colleagues and yourself, and you think of risk of the patient, and then after 1 or 2 days you start antibiotic and you think that, okay, my decision was not correct. Can I stop the antibiotics? Can I narrow the spectrum or de-escalate therapy, or can I go to oral therapy? And what is the duration of antibiotic therapy is needed for my patient's diagnosis? So diagnosing hospital-acquired pneumonia, there are 2 types. One is ventilator-associated pneumonia. So just a hospital-acquired pneumonia includes clinical symptoms of pneumonia plus hypoxia plus a new radiographic infrared, because there may be a patient admitted with something else, and if that is maybe that is a worsening of that shadow itself, that pneumonia itself. But in this case, there is a new radiographic infrared that develops. The time period is important, at least 48 hours after hospitalization. So this was actually in olden IDSA classification, we had an healthcare associated pneumonia as well. But later they realized that there is no need for that terms, and majority of them also having Pseudomonas. So community, the pathogens are usual pathogens like Streptococcus pneumoniae, Haemophilus influenzae, and chlamydia and Moraxella, etc. But when it comes to hospital, Pseudomonas and ESBL producing Enterobacteriaceae, Acinetobacter, and Klebsiella pneumonia and MRSA. Okay. So what is the diagnostic test for hospital-acquired pneumonia? Can be caused by either community-associated or healthcare-associated pathogens. So even in hospital, we can have Streptococcus, Haemophilus, Staphylococcus, gram-negative, or Pseudomonas like hospital pathogens. Or atypical organisms are not that common. Atypical organisms are rare in hospital-acquired pneumonia. And we need to get a sputum gram stain and culture in any cases, and blood cultures in all severely ill patients. Legionella urine antigen should be considered in basic cases you suspect Legionella infection, and virus respiratory panel like multi-TOF techniques or something you can use. Viral PCR panels are very common, and the Candida species or fungal species are identified. It's not uncommon to have these species. But most of the time they are colonizers rather than a real infection. So the question, an IDSA guideline, the question, thanks for the slides to the IDSA, whether antibiotic, questions of antibiotic, whether suspected VAP, and when the cultures are below threshold, the threshold value of the cultures, I'll come to the next slide. When it is low, whether we should stop antibiotic or not. Actually, the answer was antibiotics withheld rather than continued, but the evidence is weak because the quality of evidence is not strong, because the thing is that degree of clinical suspicion is important. And if the patient is already having sepsis, you cannot withhold an antibiotic. And after you start antibiotic and there is a clinical improvement, we cannot stop the antibiotic. But we need to always exercise caution to see any likelihood of an alternative source of infection, whether the antibiotic we gave is correct. So if the colony forming units are less, according to the criteria in BAL or sputum sample, we need to double think whether to continue antibiotic or not. And another question is that whether the antibiotic therapy should be guided by microbiological testing. Actually, the microbiological testing performed non-invasively and should be actually a guiding principle for starting an antibiotic. And again, you need to consider the questions of clinical suspicion, sepsis, severe sepsis, and other, if the patient is improving on the current regimen. But still, the microbiology should have give some weightage. And non-invasive methods include spontaneous expectoration, sputum induction, nasotracheal sectioning, endotracheal aspirations, all these things. And sometimes, very rarely, we need a bronchoscopy and bronchospecific lavage, but this is a difficult topic in COVID-19 era. As all of you know, that doing invasive techniques are a questionable thing, and we may be needing PVPR suits or something for doing such procedures. So Dr. Imad will be talking about this topic in detail, but as a part of ventilator-associated pneumonia, I cannot leave it without touching this slide. So who is the major risk factor for multi-drug cells pathogen? The treating doctor, without any doubt, including myself. So prior risk factors of MDR, ventilator-associated pneumonia, prior intravenous antibiotic use within 90 days. Risk factor for MDR, HAP, prior intravenous antibiotics within 90 days. Risk factor for MRSA, prior intravenous antibiotic use within 90 days. Risk factor for MDR Pseudomonas, prior intravenous antibiotic use within 90 days. All this is the major common factor. But in MDR, then septic shock, KRDS, 5 more days of hospitalization again, and then renal dialysis patients. But majority, like the baseline is prior use of antibiotics. So prior, we cannot avoid using antibiotic, but prior use of antibiotic should be like by using a proper wisdom, and proper guidelines should guide us to use which antibiotics to be used in such situations. So the threshold values of culture specimen in the diagnosis of pneumonia, as I mentioned earlier, lung tissue, if you are taking lung tissue, more than 10:4 colony forming units, and bronchoscopically obtained specimens, if it is BAL or protected BAL, more than 10:4. But in protected specimen brushing, even more than 10:3 is important, and mini-ball more than 10:4. And sputum, mild, moderate, severe growth, we are classifying like that in some cases. And in then suspected case of VAP, what we do, risk factors for MDR pathogens, as I mentioned earlier, like prior use of antibiotics and all we have to use. And then we ask for a broad spectrum antibiotic and empirical therapy and narrow spectrum antibiotic. Assessment, we have to reassess in 48 to 72 hours. And known clinical improvement or CPS score, I will come to CPS score later, and quantitative culture has to be done. If the BAL is more than 10.4 or protected specimen brushing more than 10:3, modify antibiotic based on sensitivity report. If there is a clinical improvement, quantitative culture again, and according to the culture, we can de-escalate the treatment. And if the culture is like not suggestive growth, we can withhold antibiotic. So empiric therapy, what we usually do, usually we have to give in empiric therapy or hospital-acquired pneumonia, like cefepime, this is for hospital-acquired pneumonia, not a patient coming and admitted, just coming and admitted with pneumonia in a hospital or a COVID infection. No, this is a regimen we use for hospital-acquired pneumonia. Cefepime plus or minus aminoglycoside or ciprofloxacin or levofloxacin if severely ill, plus or minus vancomycin or linezolid, depending on the chance of MRSA. Or another regimen is piperacillin tazobactam plus or minus aminoglycoside or ciprofloxacin or levofloxacin if severely ill, plus or minus vancomycin or linezolid as if it is suspecting MRSA. And reason, maybe the people already received, like in COVID situation, a lot of patients are changing hospitals now because there is no bed available in some place and they are shifted to another place, and maybe one ICU is not available in some place. So they may be already on cefepime or piperacillin tazobactam. And in that case, maybe we can go for meropenem. But instead, what we use that in the beginning, we are pushing them on meropenem. Then there is no antibiotic left for us to use. And if there is severe penicillin allergy, we can go for aztreonam plus or minus aminoglycoside or cipralevo or vancomycin linezolid in any case suspected MRSA, because always in viral infections, gram-positive infections has to be considered in any situation. So that's the thing regarding the antibiotic usage. So then empiric MRSA therapy for hospital-acquired pneumonia. When should I add anti-MRSA coverage on an empirical basis? The question answer is elevated local prevalence of MRSA. In some hospitals, MRSA isolates will be 20% or more. Such situation you need to consider. And known history of MRSA colonization or infection in that patient earlier, because some of the patients with bronchiectasis or structural lung disease, maybe they have MRSA colonization. A negative MRSA nasal surveillance swab suggests that is the importance of nasal MRSA swab when we are doing when the patient comes to the hospital from another facility. So because if it is negative, there is a less likelihood of MRSA in that case. And intravenous drug use, multiple drug use, necrotizing pneumonia, if there is a cavitation or pneumatocyl formation or something, you need to consider MRSA. Ill-appearing patient with a recent stay in nursing home or skilled nursing facility, where the patient is in some other facility and the patient is looking ill. And the hemodialysis patient, always this nephrologist, they keep on chronic dialysis on vancomycin 1 gram per every 5 days or something they're keeping to reduce the MRSA infection in cases. I have seen by many of the nephrologists that practice. So then question comes the new fancy antibiotics like linezolid, whether vancomycin should be preferred or linezolid. And both are actually reasonable options for MRSA coverage for pulmonary infections. At least 4 meta-analyses are published and shown use of vancomycin versus linezolid for the treatment of MRSA pulmonary infection. Similar outcomes. There is no difference in outcome, but we have a mental block in using vancomycin because of red man syndrome, which happens once in a blue moon. And so most of the time I go for teicoplanin, but it's equivalent actually. When the vancomycin and teicoplanin is equivalent, almost similar spectrum. And linezolid is actually similar yield. And daptomycin is in pulmonary infection may not be a suitable option because it is inactivated by pulmonary surfactant. And de-escalation is very, very important. As I mentioned in the earlier slide, in MDR cases, when there's clinical improvement and then you get a microbiology result, and the microbiology is showing it is Pseudomonas only, then you direct to Pseudomonas. If the microbiology is showing MRSA, go for that. If the microbiology is just showing a Klebsiella, treat Klebsiella only. So you don't have to expose many antibiotic, and next episode of sepsis comes, we don't have anything to use. So always save antibiotic for possible use next time when the patient is having. If the healthcare associated pneumonia is likely diagnosed, use sputum cultures to narrow the therapy. Then oral step down. When to oral step down in hospital-acquired pneumonia? Consider oral therapy after a patient shows clinical improvement and ability to tolerate medicines. That is important. The patient is vomiting or having loose motions. Don't push the patient to oral therapy. And de-escalation, as I mentioned, by culture reports. If Pseudomonas coverage is required, oral levofloxacin or Cipro is okay. Levo is more preferable because it has some gram-positive coverage as well. And Pseudomonal coverage is not needed. Consider like cephalosporin or amoxicillin clavulanic acid. And if there is a severe penicillin allergy, always respiratory fluoroquinolone is an option for step down. So what is the duration of therapy? It's not like the more the better, because now we all afraid of stopping antibiotic, and we continue the antibiotic. In a double-blind clinical trial in 51 French ICUs, and patient was randomized to 8 or 15 days. I admire their courage to randomize in this way for a study, because always we are afraid to stop antibiotic in ICU somehow. And there was no difference in all-cause mortality or length of ICU stay comparing the 8-day and 15-day. There was nothing. And on the contrary, multi-drug resistant bacteria emerged less frequently in patients who received 8 days of antibiotics compared with those who received 15 days. It's a reminder for me more than any of you, because I don't stop most of the time at 8 days. So what is the use of fancy things like procalcitonin or CRP? So the IDS is telling that using clinical criteria is more important than PCT plus clinical criteria. But in COVID-19, a big study has published recently and showed that procalcitonin predicts mortality, but not bacterial infection. So the more procalcitonin patients, it shows that there is a more like mortality like chances, but not like a bacterial infection. And the same with the CRP also. So just for CRP, especially in COVID, we know that COVID inflammation also increases CRP. So just based on CRP, we cannot guide antibiotic therapy in hospital-acquired pneumonia, especially in the setting of COVID. So what is clinical pulmonary infection score, CPIS? So it's a combined variable where you measure temperature, WBC count, PaO to FaO2 ratio, chest X-ray, progression of infiltrate, quality of tracheal secretions, and culture of aspirate. And score of more than 6 is considered suggestive of VAP, but even though specificity is not that much. And temperature, as I mentioned in the slide, each temperature has a score, 0, 1, 2, and leukocyte count within the range it is 0, below 4 or more than 11,001, and if there is a lot of bad cells, it is 2. And tracheal secretions, mild 1 and purulent 2. And radiographic findings, diffuse, patchy infiltrate 1, and localized 1 lobe pneumonia like that, it becomes 2. And the cultures also same. ARDS present 0, ARDS not present 1. But this also, you can put a scoring, but even your clinical judgment is even superior than scoring alone. So in short, a pneumonia develops 48 hours after following. If it is intubated, it's called a ventilator pneumonia. If it is just hospitalized, hospital-acquired pneumonia. Patient has any of the ventilator support, septic shock, IV antibiotic within 90 days. And patient has any of ARDS prior to ventilator pneumonia, septic shock, IV antibiotic, acute renal replacement therapy. If it is yes, MRSA coverage is required, and 2 anti-pseudomonal antimicrobial agents of different classes, like maybe piperacillin tazobactam plus aminobutyric acid or levofloxacin or fluoroquinolones. If there is no risk factor, and actually again I told you the prevalence of MRSA If there is a 10 to 20% MRSA in hospital, isolates or unknown MRSA prevalence, then add MRSA coverage. If no, the prevalence is low, the structural lung, if the patient is having a structural lung disease, then the chance of Pseudomonas is more. Then you add anti-Pseudomonal activity agent, and which has like a MSSA activity. MSSA means methicillin sensitive Staph aureus. So like piperacillin tazobactam has very good activity. So such antibiotic you can select. So what is I presented an earlier slide to introduce you, like what is the prevalence of community infections in when the patient present to with COVID-19. But when it come to a VAP and COVID-19 is associated with an increased risk of VAP, which is not fully explained by the prolonged duration of ventilation. Because all our other studies in other patients, it's mainly the duration of ventilation which guides the infection. But here also duration has a role, but still the pulmonary dysbiosis, like dysbiosis means some sort of immunological changes in the lung, which produces secondary pneumonia and causative, actually the organisms, when we identify, it is almost similar, but the death, actually VAP-free survival in non-COVID is much better compared to COVID-19. So how we will diagnose this is actually a published paper in critical care in 2020, end of, I think, October 2020. So there is a clinical feature suggestive of hospital-acquired pneumonia or ventilator pneumonia and immediate respiratory secretion sampling before introduction of new antibiotic, yes. And direct microscopy specimen and molecular testing, hemodynamic instability or severe hypoxemia, then start antibiotic immediately using the guidelines from European ICU. So European guidelines, you start. The antibiotic guideline is same like as I presented the VAP guideline, even in COVID. This is actually a COVID guideline. Then if it is like no, then low probability, no new infrared, minimal and stable ventilator settings. If it is yes, then postpone antibiotics. Look for extrapulmonary infection, re-evaluate after 6 to 8 hours. Like that is importance, no? Like don't leave the patient for 24 hours. You re-evaluate the patient next shift again. Like after at least after 12 hours, re-evaluate. Any of these things comes, you start antibiotic. If not, wait for starting antibiotic. If the patient is having high probability of VAP or HAP, again you start antibiotic based on the local guidelines and based on the pathogen and based on our guiding principle is IDSA guidelines on VAP. Based on that, we will select the antibiotics. This is the spectrum I wanted to present. The slide was a little came late, but the organisms are almost same when they culture.
Dr. Harris?
Yes, sir.
Could we have a lot of slides or are near to?
No, it's almost finished.
Okay, okay.
Almost finished.
Okay.
So almost same spectra it is. And in case of ECMO, the patient is having patient requiring ECMO are particularly prone to develop late onset VAP when the patient, because the patient is in the ICU for a long time, frequently caused by and cephalosporin producing Enterobacteria and Pseudomonas aeruginosa. So this one guideline I just wanted to present, like what is empirical therapy by NICE guidelines. Options include doxycycline, then 100 mg, 200 first day, then 100 mg, and or augmentin, then with clarithromycin. And in severe pneumonia, when presented in community-acquired pneumonia, you decide to treat levofloxacin. And intravenous antibiotic, again, augmentin, comoxiclav, I'm sorry to use the trade name, comoxiclav plus clarithromycin, or cefuroxime plus clarithromycin, or severe pneumonia, use levofloxacin. But I just want to present the hospital-acquired pneumonia. Again, non-severe pneumonia comes, same spectrum which I presented for community-acquired pneumonia, but here quatrimoxazole also they used. And intravenous antibiotic, instead of amoxicillin clavulanic acid, it will be piperacillin with tazobactam or ceftazidime 2 grams 3 times a day or levofloxacin. And in, as I told you, vancomycin or teicoplanin or linezolid can be used for hospital-acquired pneumonia for MRSA coverage. But meropenem like medications, like we are used for a second stage, not like in the beginning to step on to meropenem. So in a different series, and it's published just like 1 week back, there is a lot of coronavirus disease-associated pulmonary aspergillus were identified in cases of COVID-19, especially from Johns Hopkins Medical Center in Baltimore and Hospital Clinic of Barcelona in Spain, and affects almost 20 to 30% of severely ill mechanical ventilation patients with COVID-19. So it's a very important observation, and we also seeing some of the patients. And this slide, I'm not going to go through details because my time is up. This is a total guideline published on February 22 by IDSA, CDC. And here actually the main thing is suggested use in corticosteroids and tocilizumab, good evidence is coming, and remdesivir also. And remaining medications are still on trial phase, a lot of them. And hydroxychloroquine or lopinavir, it's almost recommended against use. So to conclude, secondary bacterial infection is not a norm in COVID-19 infection when it presents first into the hospital. But antibiotic prescription is quite common, and causative organisms for a hospital-acquired infections are similar to non-COVID patients. And COVID-19 patients with the co-infections are more likely to die than patients who do not have co-infections. That is quite expected. Respiratory sample collection is challenging in COVID-19 cases because of the infection control procedures. Increased prevalence of fungal infections are noted in some series, and guiding principles of antibiotic management is similar to non-COVID cases, and guidelines and evidence are still evolving regarding adjuvant therapies like monoclonal antibodies or something like banavilimab, and so many medications are on the way, but the guidelines and evidences are still evolving. Thank you very much. Thanks all healthcare heroes, healthcare workers who sacrifice their lives, including my colleague recently lost his life. And our knowledge is evolving. Knowledge is never complete in COVID-19. I don't know when I will have a proper knowledge about treating COVID-19. Thank you very much. Thanks for the opportunity again.
Thank you very much, Dr. Harris. It's really very difficult topic, I know, and you cover it really very interestingly and updated us with how to deal with patients with secondary bacterial infection in the COVID era. It's really very informative, very nice lecture. You make it easy for us, and I hope one day we'll end this COVID era and we'll be back to normal. Actually, we have, and you are as always very interesting lecture as always, Dr. Harris. And I have 4 questions, but for the sake of time, we'll take 2 of them. First one, they ask about validation for scoring of HAB in the hospital. I say, what is you think the best score we can use? You already mentioned.
CPA score, I think because if you put a score, the still CPA score which I presented is hold true. Like it covers almost everything, but still the specificity of the scoring is not that very good. But each regional society, like our Emirates Thoracic Society, or like any other society, critical care society, we have to formulate our own scoring in our own places. So that'll be very advantageous for the local market, because each area there is challenges. But as a whole, as a guiding principle, we can use the CPA scoring for validating the hospital appointment.
Yes, CPS scoring, actually, yes, you are right, because the specificity and the specificity for this scoring, there was one study, they compare the clinical score before and after post-mortem, and they found a big discrepancy in between them. When the clinician takes the score, it was specificity was around 70 to 80%. When post-mortem, they found it 50 to 60. So still, we need another better score, and I agree with you, we should have our own local guidelines. The other question is asking you about should we ban moxifloxacin from use in our clinical respiratory infections? Do you think that moxifloxacin should be banned at all, or as other quinolones? You know, this message come to all clinicians, especially GPs, that quinolones have side effects and should be banned unless you have other alternative. So what do you think, Dr. Harris?
No, until now, I haven't seen any data that to ban the respiratory flow or moxifloxacin, especially because now there are a lot of people putting a lot of studies on the system, and mentioning like famotidine were tried for somebody for COVID-19 and so many things. But as such, there is no compelling evidence for us to stop. But as I presented in the data for a hospital-acquired pneumonia, and we don't use moxifloxacin in that spectra, Anyway, I'm sure that in your next lecture, you will be dealing with antibiotic proper usage in the hospital. So you will be answering that question in a more better way. I think you will enlighten the audience.
Yes, I think we should only make sure that the patient has no previous ligaments or orthopedic problems before we start, and we have to stick to the age of the patients, because some people will use fluoroquinolones in younger age than 18 years. So it's really sometimes it is the only drug we can use. So I agree with you. We still have to use it. The last question, Dr. Harris, asking about the immunity post COVID-19 and how we measure it. Of course, we know that we measure antibodies against COVID, but the audience is asking you, do we have all patient gets COVID-19 gets immunity or not?
Again,
No,
answer.
yeah.
But available data, I think the majority of the people get, because when we check also, like majority get antibody, but the development of antibody, which titer is cut off for antibody, I don't know that to answer that question, because some people, like old people I have seen, like some of them develop antibody titer of 4, but at the same time, youngsters are developing like 190, something like that.
Yeah.
So what is the exact cutoff?
Yes, some people get high immunity titer, and other people does not. We don't know the why, but we'll see, Dr. Harris. Thank you very much, brother. It's a really interesting lecture, and you get very hard work on it. Thank you very much.
You're welcome, sir. Thank you. Thank you so much. Now, my friend, Dr. Imad will be presenting next lecture on antibiotic in the hospital settings. Very, very important topic. And Professor Imad has a wide experience clinically and academically, and he's an academic professor in Egypt prior to coming to Sharjah to work with us. So I think this lecture will be very much enlightening for us in coming few minutes.
Thank you very much. Actually, Dr. Harris, at first I'd like to thank Dr. Ashraf again and AstraZeneca for this great opportunity to be with you today. Actually, Dr. Harris has give us a very interesting lecture on using antibiotics with COVID era, and he make it easy for me for my lecture. Actually, this old scientist said, without accurate data, we are just another person with opinion. So without data and without analyzing this data, we'll not be able to have accurate decisions. And anyone who said my experience so and so is not accurate, because we have to look at other data gathered by scientists. Concerning healthcare associated infection, as you see here in this figure, this is about more than 1 million infection across the healthcare in America, and they have about 30 billion cost per year for infections, and urgent 6 serious antibiotic resistance emerge every year, and 1 in 25 of people admitted to the hospital in US has get nosocomial pneumonia, nosocomial infection. As you see, the distribution between the cost per 1 episode of infection ranging from 9 for urinary tract infection up to $45,000 for central line infection, and for ventilator-associated pneumonia about 40,000. Cost to hospital-acquired infections in US around 10 billion US dollars every year. Double the number of people died from traffic accident in US have hospital patients dying from healthcare associated infections. And our concern in nosocomial pneumonia or infections is concerning the hospital-acquired pneumonia and ventilator-associated pneumonia. And there is high mortality and morbidity about hospital-acquired pneumonia. It is the second most common nosocomial infections concerning gram-negative bacilli as predominant, which has antibiotic resistance higher than gram-positive organisms. The organisms are very bad, and as you see, more resistance is coming in our patients. And most important organisms, including carbapenem-resistant Enterobacteriaceae and multi-drug resistant Acinetobacter and multi-drug resistant Pseudomonas aeruginosa. And they caused a lot of mortality and antibiotic use in the hospital setting. When we started antibiotic like penicillin in the 50s, the organism was intelligent, and we get penicillin resistance, Staph aureus, then methicillin came up and methicillin resistance, and then vancomycin resistant enterococci, and then vancomycin intermediate resistant Staph aureus, and now we have vancomycin resistant Staph aureus. So whenever we have new antibiotics, the organism become intelligent and become resistant to antibiotics. There is very bad impact on antibiotic resistance, and in the patients is slower response, is more expenses, more investigation, more ICU stay, more hospital stay, longer duration absence from work, here more mortality, hospital more expensive therapies, more money spent on the control, more cost against the side effects, and this investigation. Society have a risk of spread of infection. In the 90s, when I was in the States, there was only one reported cases of methicillin resistant staph, and then we have this MRSA in the community and multi-drug resistant organism. I have some patients come with multi-drug Pseudomonas in the community. Just he had get it from family member or relative has hospital infection or resistance. And always the ARS were talking since early 20s about protocols in the ICU, but still we need antibiotic protocols or optimizing protocols for antibiotics. Why? Because if we don't give the right antibiotic or adequate antibiotic, like the antibiotic is not covering the infection, or the pathogen resistant to the group, or the dosing is not adequate, or we didn't use combination when we have to use, then we are adding mortality to the patients. This is a study we did in 2000. As you see, if you treat your patient adequately, the mortality is half if you don't treat it adequately. So this is very important message. If you don't treat your patient right from the start, you are adding mortality to your patients. In all nosocomial infection, including from Lerma, Lero, Colif, and myself and Luna, if you combine the initial appropriate antibiotic and initial inadequate antibiotic therapy to the mortality, you find all the mortality increase with inadequate therapy. Not always this only, but also if you look to this slide, you find that inadequacy of therapy for patients who has vancomycin resistant Enterococci or Candida, and comparing to Klebsiella, Pseudomonas aeruginosa, if you inadequately treated the patients, the more mortality occur with patients with gram-negative. So it is more serious infection, more serious effect. How we can optimize antibiotic protocols in the hospital settings? There's many topics about this one. Locally developed antibiotics, and this is why Dr. has already mentioned about, and always we ask Dr. Arshaf that we have to use our society to develop local guidelines for antibiotic use in the community acquired and the nosocomial infections. And I think it is difficult topic, but I think we can do it. International guidelines, hospital antibiotic stewardship programs, and most of the hospitals have it now. This stewardship program help to have a committee that control the use of antibiotics. They call the pharmacy, they call the clinician and said, why you continue this antibiotics? What is the duration mentioned? And they have to initially approve the use of antibiotics. This will limit the abnormal use of unneeded antibiotics. Combining antibiotic therapy, combination therapy sometimes is needed, restricting the formulae of the hospital, and the schedule change in the antibiotic classes, antibiotic rotation or cycling, area-specific antimicrobial therapy. So if you have infection in patients with urinary tract infection, it's different from patients who has hospital-acquired pneumonia, patients who has VAB, surgical site infection. So to have area-specific guideline. Multiple intervention, this is very important. Combining the infection control with antibiotic restriction, antibiotic protocols improves the outcome of patients. The antimicrobial distillation, that's what Dr. Harris talked about it in his lecture. This is very important because this one will help to get more antibiotic conservative protocols to help us to keep the antibiotics to the most important infections and new classes of antibiotics, of course. So guidelines for nosocomial pneumonia, should we use local or international guidelines? I remember I was chairman in the European Society, and some of the big figures in Europe, in Spain, his daughter was presenting a paper about comparing local antibiotic guidelines versus international ETS guideline or ERS guideline. And at the end, she said the compliance with international guideline was more than local guideline. And when I asked her why, I said because people are more aware about international guidelines than local guidelines. I remember we have a local guideline for community-acquired pneumonia with Dr. Nidelman and the groups from Gulf area in 2007. And I think people are not aware about this one, but aware about the ETS guidelines. So we have to have our local guideline and as well as international guidelines if we don't have it at this time. Why we use guidelines? This improves the outcome of patient, reduce the resistance, cost effective. You will not use too much days of antibiotics. You will not use unneeded antibiotics. Drug abuse is increasing, so we have to have more guidelines. Despite the new antibiotics and infection control, there is high mortality for inadequate therapy, as I mentioned to you. There's many guidelines, including the ATS guideline and the American guideline. And of course, it is updated every 10 years for international guidelines. I have experience with local guideline in Washington University. When we collected data from our hospital-acquired pneumonias and collected the resistance pattern, and we find that most of the people who has VAB at this time, ventricular pneumonia, has Pseudomonas multi-drug resistant or Klebsiella multi-drug resistance. And you find the only antibiotics which cover these drug-resistant pathogens, we find this with ciprofloxacin and meropenem. So we put a guideline that all patients who has ventilator-associated pneumonia should be reported to me, and I use the guideline of SCCB to define the hospital-acquired VAB, and then we started the protocol. We started ciprofloxacin and imipenem, and because the Washington ICU has high incidence of MRSA at that time, we use vancomycin as a combination. And we send the cultures, and after 48 hours, we collect the culture. If the antibiotic or if the antibiotic covering the pathogens we have started with, we continue same antibiotic. If the antibiotic culture shows another antibiotic, we change the antibiotics. If it shows different organism or candida, we stop antibiotics and go for the culture guideline. After then, we collected data about the outcome of patients who use the protocol, and of course other people who is using their own experience. We find that if you use the protocol, we have a half percentage of inadequacy. So if you use the protocol, you are giving more adequate therapy to the patients, and if you don't use the protocol, there's doubling of inadequate therapy. Also, the duration for antibiotic was reduced to half of the duration. The people who used their own experience, they used about 14 to 16 days of antibiotic, where we use about 7 days to 10 days of antibiotics. So it is cost effective and less duration of treatment. Also, the second attacks of VAB was less with people who had the protocol. So we have less people in the second attack of VAB when we use the protocol. So it means that we have to use our local guidelines, and I think each hospital should have its own guideline, not only local Emirates guideline, but I think also we should have a different ICU and protocols for surgical ICU, for medical ICU, for infections, nosocomial infections. The word it should be different. Stewardship program are also very important. We can use it to improve antibiotic utilization. This is a group of expertise in the hospital, including the lab, including the ICU, including the pharmacy, and including medical and surgical personnel with experience about antibiotics. What they do, these people? They just look to the gram-negative, especially gram-negative antibiotics, because this is more important that we have too much antibiotic resistance with gram-negative. So this expertise, they implant the action when they receive the request for antibiotics. They review the patient. This is this patient. Yes, we can use this antibiotics as empirical therapy, and they track the antibiotic, how many days the clinician use, and then they call the clinician and said, stop. You have to stop or to change antibiotics as long as you are using antibiotics for more than the duration, or the patient has other recommended antibiotics. So antibiotic stewardship gives the right antibiotic, the right patient, the right time, the right dose, the right route, and the right duration. So this is all about it. So it is improve antibiotic utilization in the hospital setting. Combining antibiotic therapy. There's a lot of data about combining antibiotic therapy, but as you know that, for example, carbapenems, if you combine it with aminoglycosides, they found in the ETS guideline 2016 that there's no difference between adding aminoglycosides without adding combination therapy. And then when we come to combination, should we use vancomycin, piperacillin, tazocine, cipro, or vancomycin, cefabime, cipro, or linezolid, meropenem, amikane, linezolid, ceftazolone, tazobactam, or linezolid, ceftazine, alfabactam, or fosfomycin? It is a lot of combination, but it should be with your local flora, about the local flora and resistance. You can use the best combination. In cases of patients outside the ICUs and they have simple no comorbidities, and they have non-sensitive pathogens, so you can start with one antibiotic alone. About restricting the hospital formula, we shouldn't have all the formula on board. We can use for certain antibiotics from gram-negative for center period, and then we change every 6 months or 3 months. A scheduled change in antibiotic classes is also very important. It helps reducing the overload of use one antibiotic. About rotation or cycling, we use this rotation in Washington University when we said, for example, in the ICU, the drug of choice this month for gram-negative will be meropenem or Tynam, for example, for 3 months, and then after 3 months we said the drug of choice will be ciprofloxacin, and then we collected the data. What we found every time we use the anti-gram-negative antibiotic, and then by the end of the cycling area, the resistance become higher and become more organism resistant to the class we use. So we recommended to use 3 months cycling of antibiotics, and this could be helpful in areas where there is no much antibiotic resistance in the ICUs or hospital. Area-specific antimicrobial therapy. So when you treat patients with urinary tract infection or nosocomial bacteremia or nosocomial pneumonia or nosocomial surgical infections, there should be area-specific guideline for each of this infection. Multiple infection interventions and antibiotic restriction could help, because we have to making the healthcare safer than using similar antibiotics for all the people without infection control. Infection control is very important as it helps reducing the spread of infection of resistant antibiotics, and but the compliance is low, about 40% only the compliance. So in one study, when they use they collect the infections in 5 years, comparing to combining nosocomial control, infection control, there was higher percentage of better efficacy in controlling the infection. Antibiotic distillation is very important because when we start, for example, combination therapy like carbapenems and or tazobactam, tazocillin, and they use aminoglycoside, and then when you culture camp, you distillate antibiotics. This is very important to save antibiotics. New classes of antibiotics, of course, this is important, and they can help in improving antibiotic utilization. And instead of using combination therapy, instead of using many antibiotics, some antibiotics are covering better than combination therapy. The pro is new antimicrobials that it is potent and effective. Usually this is so toxic than alternative like colistin or aminoglycosides. Microbiologically, it is very active, may improve the outcome and shorten the length of stay of patients, most of them eligible for carbapenem sparing strategy. But the cons about it is we have still limited experience about randomized controlled trials. We have no evidence superiority for the competitors, so we have the similar studies. They said at the end is the superiority is not there. There is no knowledge about long-term effects of these antibiotics. They are very costly, and we need to reserve them for needed patients and not widespread use. Is some randomized trials about new antibiotics versus old antibiotics, and all of them, most of them, does not reach any superiority of the old antibiotics. Is a critical balance when we use antibiotics. We have to identify the source of infection to narrow the treatment and to use distillation of empirical therapy according to cultures and sensitivities. Importance of approaching empirical survey from the start. You know your most common pathogens, is ICU or the respiratory infection or urinary tract infection. So you give the right antibiotic from the start. And when you don't use appropriate antibiotics, you increase the mortality. The increased resistance in the infections. You have to make sure that you use broad spectrum antibiotic to limited patients. Cost effectiveness should be also on board for patients with hospital acquired infections. Clinical guidelines should be employed to improve our overall utilization of our specific hospital acquired infection, and this antibiotic protocols could be computerized or mentioned to the clinician. There's one trial in Salt Lake Hospital where they make computerized local guidelines. When you put patient data, the age, the gender, the site of infection, the comorbidities and age, you will find, and you will find at the end one screen told you this infection usually is due to Pseudomonas or to Klebsiella, the most effective antibiotic, and so on. So they use these antibiotic protocols and they get very good outcome in these patients. Of course, you have to do adequate therapy from the start, careful choice of antibiotic to avoid unnecessary use of antibiotics, and each unit and each hospital should have its own antibiotic protocol. So don't use inadequate therapy, and we can prevent hospital acquired infections with collaboration between infection control and different departments. Also, we have to have our data, accurate data, and evidence-based practice. But still, you have your own experience in treating patients. So the textbook or the guideline is not meant to overcome clinician experience, because this talk, a person could die if you use the textbook, if he died of misprint. Guidelines are meant not to replace attending physician decision. We have some questions. For the sake of the time, Dr. Harris, I think I'll take two of them. Is it okay?
Okay, please.
Okay. So the first question says, which antibiotic to start for patient diagnosed with HAB before culture results come? So this depends on the patient. Is it this patient has comorbidities or has previous admission or previous antibiotics, as Dr. Harris said before. So if it is for the first time of HAB and he has no comorbidities, I think we will start with broad spectrum anti-pseudomonal treatment. We can give, like as the guideline says, with carbapenems or tazocin or tazobactam, piperacillin, or we can take one of the third or fourth generation cephalosporin. If this patient has comorbidities and has high score of infection and he has previous antibiotics, so we have to use combination therapy, either carbapenem besides fluoroquinolones or like Sabro or not. If you have suspicion of MRSA, you have to add anti-MRSA treatment. This another question said, what is the best medicine for treating respiratory problem? I think I don't know the specialty. Specialty should be pulmonologist, and then we should use the guidelines. I believe that NICE guidelines do not apply to us. We have high resistant organisms. Dr. Nihad, yes, I agree with you. It's sometimes we have high resistant organisms in certain areas, not all ICUs or hospitals. So you have to use your own guidelines. How to develop local guidelines? Very simple. You make a committee from the clinicians, from different departments, and from the lab, and then you collect the data, for example, for last 3 months or 6 months, and you know how much, what is the organism there and what is the resistance better, and then you can put your own guideline and can use also this data to give advice not to use certain antibiotics for a period, because sometimes if the patient overload on carbapenem, the resistance of Pseudomonas and the Citrobacter is high, so you have to stop using the antibiotics, replace with other antibiotics for 3 months, and then you use it again. Okay, Dr. Harris, you have the lead.
Okay, thank you very much. I agree with you. Like it's like each hospital cannot be compared to another hospital. When there is a like 50-bedded ICU hospital cannot be compared with a 6-bed ICU hospital, because that maybe resistance spectra will be different, and this small hospital, the resistance spectra will be different. So local guidelines are important. I totally agree with you. Thank you very much. And I think with this, we would be able to conclude this session. Thank you, Dr.
Yes.
Martin, for giving me an opportunity.
Thank you, Dr. Harris, very much. It's a pleasure.